Hello, and welcome to our webcast. I'm Janie Pennington with Moss Adams, and I'm getting us started for today's session, Enhance Patient Access While Supporting Provider Wellbeing. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
And now I would like to introduce today's moderator, Marnee Iseman, a partner within the Moss Adams Healthcare Consulting Practice. Marnee, I'll let you take it from here.
Thanks, Janie. Good morning, everyone. And thanks for joining us for what we hope will be the first in a series of conversations about one of the most pressing problems we have in the industry today, access. Today, our objectives include understanding how leaders can approach what are sometimes considered opposing goals of improving access and provider and care team well-being. We're going to talk about that quite a bit. We'll talk about strategies for improving work processes and how those enable access improvement. We'll gain organizational insights around the ramifications of poor access for not just your strategy or your operations, but also your strategy. And then we'll take some Q&A at the end. I want to welcome our guests for today. I am lucky to have 3 illustrious experts in the field. The first is Jenny Berry. She's the COO for the Christ Hospital Physicians, and she leads the development and execution of operating goals and continues to enhance the quality patient-centric care that the group is known for in the Cincinnati area. Her responsibilities include leveraging technology to improve care coordination, employing and training the best talent, optimizing office operations, and coordinating the Christ Hospital experience with their experience officer to provide the very best experience to their patients. Jenny joined the Christ Hospital with over 30 years of healthcare operations experience and is going to share her many tales of access improvement with us today. Erin Adams is a healthcare executive who's held executive leadership roles since 2000, including hospital president, CFO, vice president of enterprise transformation. He has expertise in hospital, ambulatory, and healthcare operations, strategic and financial planning, transformative change, and leadership development. Erin assists healthcare organizations in achieving their operational, patient safety, clinical quality, and financial priorities. And then finally, Dr. Kim Pittenger, who began his career in family medicine in 1979. By 2004, he'd become a strong believer in the Toyota Production System's ability to ease quality care delivery while also boosting financial success and maintaining stable practices in primary care. He became a fellow, Kaizen fellow, certified by the Virginia Mason and Shingijutsu Consulting firms in Japan, and joins us today. Welcome, everybody. So we're going to talk about a problem that is deeply rooted with challenges in our industry. If you bother to read any of the current information about access, wait times just continue to click away at getting worse and worse. A recent Merritt Hawkins survey indicated that access delays for primary care had risen to an average of 26 days. That's up from 18 days in 2014. So that's about a 50% increase over the last decade. And specialty care, according to the AMA, is running at about 6 to 8 weeks on average to get access there. In a poll that MGMA did after the peak of COVID, asking practices whether or not access was getting better in their organizations, only 25% reported that to be the case. That leaves the vast majority of practices reporting that things are not getting better, and that's part of what we're going to talk about today. And the demand isn't making things any easier. The population is aging, and along with it, bringing a treasure trove of chronic disease. In a AMA interim House of Delegates meeting that just happened this week, there was a really interesting commentary that while patients, by and large, have a high level of trust in physicians specifically, they see the increasingly difficult accessibility to care as a major issue. And then patient expectations around this network integration idea, or the omni-channel aspects of access, both virtual and in person. And we'll spend most of our time today focusing on in-person access as a first element. All of those are increasing the stakes and expectations for organizations. And then finally, the workforce. Who do we have able to provide the access? Provider shortage forecasts are pretty alarming. The AMA puts the predicted provider shortage by 2034 at 124,000 physicians. Mercer predicts that by 2030, there'll be more than 3 million open medical assistant positions looking for at the same time, the work burden itself has significantly increased. And that leaves us with a less than stellar feeling about how EHRs are or not helping with that work burden. Jenny, I know you've had some thoughts about how the context of all of this related to access has changed pre and post COVID. Can you talk a little bit about how you see things in your neck of the woods?
Yes, thank you, Marnee, for asking that. I really feel like access has always been forefront for all operators. That's what we do, especially in the outpatient setting. We need to get patients in as quickly as we can. I found that the demand for that as a leader in operations was very much present pre-COVID. But what I've found post-COVID, it's more prevalent and more demanded by our leaders, our executives, our CFOs, our CEOs, because of the impact of our financial state. Our expenses continue to go up. What we have to pay for our people to be here and to work, and our reimbursement continues to go down. So the only, in our minds, the only answer to that is we got to get more patients in. We got to see more patients. We have to generate more revenue. And the problem with that is after going through COVID, there's been a significant increase in pressure on providers, but also administrators, team members. As you mentioned, the staffing attrition, I recognized after COVID that just staffing the clinics has become a challenge for us. Pre-COVID, it felt like you would put a position out there and you would fill it. Post-COVID, people got scared. I believe in the industry, the folks that were on the verge of, well, I could work 2 or 3 more years. When COVID hit, they said, I'm done, I'm out. So all of those workforce shortages we were predicting 10 years ago, not just providers, but staff, really hit us unexpectedly in the past couple of years. So that is the challenge that we have when we're getting pressure from our CEOs, CFOs. We've got to get more people in. And we're looking at a workforce that can't handle the additional influx, and providers who are also saying, I am burnt out. I want to spend time with my family. And it's really a difficult situation for all of us to be in.
Thanks, Jenny. Let's ask all of you. Let's go to our first poll. Jamie?
On average, how long does it take how long does a new patient wait to be seen in your organization for an in-person visit? Your answer options are same day, 2 to 3 days, 1 week, more than 1 week, more than 1 month, or I don't know. I'll give you a few minutes to respond. To participate, please click the answer you choose and hit submit. If you can't see the submit button, please enlarge the slide viewing area. And you do have the option to submit questions for us in the Q&A window. We have quite a bit of content to cover today. So if we don't have time to respond during the webcast, we will follow up with you afterwards. Looks like we have about 75% of you that have answered, so we'll give it just a bit more. Okay, and here are your results.
Interesting, team. Take a look at that. Look at the number of same day, almost 20%, and 35% within 3 days. How does that compare to Aaron and Kim to what you're seeing out in the market? And let me just point out, we were trying to ask this around a new patient getting into your organization. I don't know if this was answered from the framework of an established patient, but either way, Aaron, Kim, let's start with Aaron. What are you seeing when you're talking to organizations about their wait times?
Yeah, good morning, Marnee. Thank you. Well, as you can imagine, we're talking to a lot of different health systems on a regular basis. We're asking them about these types of challenges. And I think what we're learning, and it's no surprise, is that access is at the very top of the list when it comes to issues that people are facing. Most organizations have some dedicated improvement teams focused on this work. But I think in accordance with your statistics that you talked about on the earlier slide, even though some of these dedicated improvement teams have been in place for a number of years, they're not necessarily seeing the improvement that they would like. In fact, in many instances, not much in the way of improvement at all. Some are having pockets of success here and there, but most folks are stalled out. And I think what we're seeing is that, the alternative is they're going out and they're buying more capacity. Which is, as you can imagine, a very expensive way to try to make progress on this problem. I think the strategy people recognize the importance of improving access and how that impacts your overall business. So most organizations can't wait for the improvement to happen. So they're buying more capacity, recruiting more physicians, adding more facilities. And it's a very expensive way to go about trying to make progress on the problem, especially when you have capacity that isn't fully utilized. And I think to Jenny's point earlier, when we're strained as an industry and people are trying to get to some type of financially sustainable stance, it really puts a lot of strain on your cash flow, puts a lot of strain on your margins, and it's a difficult way to try to make progress. So we're seeing limited progress in this space. And I'll just share from my own personal experience. I just moved to a new city and I was referred to a physician. And in early October, I tried to get my first new patient visit. And the first time that doctor was available was February. And then I came back and said, well, I'll take somebody else who has the next available appointment. And the next available appointment was the last week of November. So about an 8-week lead time. So I think all these things are pretty consistent through personal experience, through discussion with others, through some of the studies that you're sharing. So it's certainly problematic and we have to do better.
Jenny, I know when you look at this metric of how long people wait, there's a hot debate right now whether or not third next available is actually the best metric or not, or whether we ought to be looking at some other measures, lag time being one of them. And you have a strong opinion about lag time. You want to talk about that for just a minute, and then we'll jump into your story.
Because it's easy to say we have thus. The third next available could be the same day. It could be the next day, but it could be that the provider will only see the patient with the right toe on the third Tuesday of the month. And for me, I think lag time is much more relevant because that is what I as a patient can take out of your inventory that works for me. So even though my third next available might be 2 to 3 days out, if it doesn't work for my audience or for my patients, and it's 3 months or 2 months or 80 days, whatever that lag time is, I think that's the number I'm going after.
Thanks. Kim, I'm gonna move forward and I'm gonna come back to you with a question. So stay tuned for just a second. Jenny, you've worked on access in several organizations, and you've said to me before that access isn't the point, but rather the happy outcome of doing what's more important, which is actually addressing the underlying operational issues that make it difficult to improve the access. Can you talk a little bit about how you've approached access? And we're showing some of the operational improvement outcomes that you've achieved, but talk about what you mean by working on the operations to get to access improvement.
Yeah, so I think that the access is really about the downstream impact of everything that we do operationally correct. So we need to get everything out of the way for our team members and providers to just see patients. And when I talk about that, when I go into systems and I see that the work is somewhat chaotic, it's not the same, there's a different approach. What that introduces is a lot of variation and time waste. So what's really important to me is operationally, how do we make sure that the things that we should do the same every time are done the same so we can worry about anything that's introduced outside of that? And I have found that access is good access, improved access is the outcome of great operations. So we really want to get to a system where we get the base really firm and secure in that we've got everything in its place, that we aren't wasting time looking for it. We make sure we have standard work. I've worked in 5 systems, and all 5, we roomed the patient basically the same way. We checked them in basically the same way. It's an 80-20 look at it. 80% of the time we should be doing the same thing, and it should become like clockwork. I always share with my new staff or new employees that it's like driving home at night and you forgot how you got there and you're in your driveway. It becomes just routine. And that's how the everyday work should become. So then we can improve upon that, remove all the waste, and open up access, both for the team members to help the providers and the providers to see more patients.
Great. And one of the outcomes that you've seen as a result of doing that work, making the work more predictable and reliable, making it as autonomic as driving home and then realizing that you weren't really thinking about how you got home, but you're there. Can you talk a little bit about the effect that you've seen on the clinician and the staff well-being? Because one of the outcomes you've got up here is a pretty fabulous attrition rate change.
Yeah, I would love to talk to that, because when I started in this organization, our attrition rate was even higher than that. And what it really came down to is if staff don't know what's expected of them or what they're supposed to get completed, they don't feel that they have any value. So as we began to roll out things like 5S and getting everything in its place, and we got them involved in that, then we started rolling out standard work and really outlining, this is the expectation, this is what we need you to meet. And they then would say to us, oh, I really actually feel like I know what I'm supposed to do now as an MA. And then we started putting up what we call visibility walls and having that conversation. And over one fiscal year, this is data from fiscal year 23, so it was July of 23 to June of 24, because of all this work we've been doing and rolling out across ambulatory services, we went from 19.6% attrition rate down to 14%. And against that industry standard, that was a really big win for us. And if you put dollars to that of the turnover expense, it's well into the hundreds of thousands of dollars. And we heard it on our employee engagement surveys that they felt like they were part of the team and the excitement was there. And then physicians, they care about that and they watch. So that just gives a little bit more, I guess, value to the work we're doing in the eyes of the physician, that we're not just administrators coming down on them. We're trying to help both them and the team members.
Thanks, Jenny. A lot of what you've talked about, I'd like to turn to Kim now. It really describes, Kim, the types of things that you've coached clinical teams to tackle when they're facing access barriers. You've done a lot of research on the connection between the way work is done and clinical team burnout. And I'm wondering if you could, over the next couple of months, some of the connections that you've seen between changing the way that work is done, a lot of the things Jenny described, reducing the variation, making it predictable, and we'll get to batch versus flow here in a minute. But doing the work essentially as it comes, really changing that approach, how that actually impacts workload and burnout.
Well, the big connection, Marnee, is that we're now in an era, and this is very positive, where the countermeasures and solutions to the dual problems of access and overburdened providers really join together in improving operations, just like Jenny said. We have sources now that can tell us that if we reduce task burden in the daily work of providers, for every 10% reduction in task burden, burnout scores go down 33%. There's a dose effect. We know that from studies on countermeasures to burnout, that workflow interventions reduce burnout scores more than do resiliency training, yoga, and meditation. We know that documenting in flow, that means right after each patient, yields a shorter, more concise note that takes less time and reduces time in notes. If you are an Epic user, that is one of the signal measures that is very high where providers spend their time. And if we reconfigure the in-basket and team up who manages which inbound flow of information pieces, then we reduce their burden in the in-basket, which is, in most surveys, the number one thing that providers don't like. All of these go together to reduce their length of day. And length of day preference is generational. Older generation providers like me would accept a 9-hour day, whereas we used to do 12-hour days. Younger generation providers really want less than a 9-hour day. And so reducing time in the EHR by optimizing the EHR, configuring it correctly, designing it correctly, and optimizing the user actually creates time for more patient care interaction. And we've all heard the studies that at least 45% of a provider's time is spent interacting with the screen more than their patients. And this can either conceptually or accurately actually increase capacity for patient visits. Okay, I'll add another patient on. This is the key to opening up access to the teams. And by teams, I mean it's not all access to the MD, not all access to the nurse practitioner and the PA. If you create teams that can give people the information they need and the standardized answer to routine low-risk problems, you're opening up access as well.
Thanks, Kim. You also talk about how changing this approach to the work, eliminating batching or reducing it and moving it into flow, again, the things that Jenny was talking about, has a direct impact on quality. Can you talk about that?
Yeah, long ago I had a friend who ran an urgent care who would say to me in the morning, when I see patients with viral bronchitis, I'm an educator and I teach them how to take care of themselves and ride through it with placebos over the counter. But in the afternoon, when I have to go pick up my kids, I'm a Z-Pack prescriber. So as each half day goes, most teams start to run behind because they haven't done everything we proposed in the preceding slide that reduces their work burden. And it makes common sense, and now we have good evidence that it's true, that cancer screens decline as each half day goes on. Statin prescriptions for high-risk patients decline as the day goes on. And physical therapy, as opposed to opioids for musculotendinous problems, goes down. Whereas opioids for those illnesses and sprains and strains go up, and antibiotics for viral illness go up, imaging and specialty consults go up. And the funny thing in the details of these studies is when you look at those first 3 bullet points on colon cancer, breast cancer, and statin treatment, the actual fulfillment of the test and the compliance with the medication goes down in patients who were at the end of the half day. There's something about the quality of the interaction that leads to adherence and compliance and engagement in care. So we have to work on being in flow throughout each half day.
Thanks, Kim. Aaron, you've worked with lots of organizations tackling transformative change efforts. Tell us about how Access is showing up there for you and what this work means.
Yeah, that's a great question. I think, again, going back to some of my earlier comments, I think some of the challenges have been normalized to some extent. And so then again, we're making the decision to buy more capacity as opposed to kind of, I think, following the prescription that Jenny and Kim are lining up. I think at the end of the day, you know, when you can improve the work and get to flow and you actually start to get that improved access, you know, everything about your business and everything that your patient experience improves. There's just a whole myriad of positive things that happen. I think this slide says all boats rise with improved access. And that's really the why behind this work. And I think the need not just to normalize the progress or lack of progress that we've experienced as an industry, but really to try to push through that. I mean, if you think about everything you're trying to do as a business from a strategic perspective, you know, if you want to grow, you need room for new patient visits. If you want to really reach a financially sustainable path, you need to be productive. You need to utilize your capacity effectively. You need more revenue. You need all of these things. You need more affordable care. And all of those things get advanced when you have good access. The same could be true for the patient, right? Certainly the care becomes more affordable for them. They have much better experience when they interact with your health system. And when you can provide care in the right place at the right time, certainly their outcomes get better. And I think the inverse is true. When you have poor access, it's very difficult to achieve any of your strategic priorities. It's hard to grow. It's hard to manage population health. It's hard to achieve your value-based care goals. It's hard to delight your patients with experience. I've seen this most recently. In my personal life, again, I have a friend who had some health issues, was trying to get in to see their provider, and they couldn't get in on a regular basis, and they ended up having 2 ED visits and a procedure. And it was all simply because they needed to have their medication adjusted. And they couldn't get it adjusted in a timely manner because they couldn't get into their primary care and their cardiologist in a timely manner. They were frustrated. They tried to do things digitally. And they ended up being cared for in the most expensive setting possible. They ended up having some procedures that they wouldn't normally have had to have. And I think that's systemic of what we're seeing in our business. If you don't have good access, you have all these extra costs and issues that occur. But again, great access allows you to see that patient in a timely manner in the right venue to prevent all those additional costs and challenges. So to me, this is the why. And I think it speaks to the fact that we need to push through the normal state that we have today, or the current state, and really say this has got to be the focal point of your strategy as an organization if you're going to be successful.
Thanks, Aaron. Jamie, I think we're at another poll.
This is our second polling question. What's getting in the way of your organization improving access to in-person care? Your answer options are: patient demand exceeds appointment capacity, provider burnout and vacancies, staff vacancies and turnover, scheduling barriers or complexities, all of the above, or something else. As a reminder, if you'd like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. Please make sure that you're selecting your answer choice within the slide window and not typing your answer in the Q&A window.
And I want to recognize there were a couple of comments in the Q&A window about the earlier answer on how long is the delay or the current wait in your organization for a new patient. There was a big resounding, it depends, which might go a little bit, Aaron, to your comment about the normalization of how much do we just tolerate with the current state of waiting. And again, with this question, recognizing that it also might depend on which specialty or which area geographically that you're talking about, but just in general, give us an idea of what's getting in your way.
Give it about 5 more seconds. We have a few more answers coming in. And here are the results.
All of the above. We have lots of work to do. Isn't that great?
Yeah.
Interesting that scheduling barriers and complexities is low. Jenny, has that been your experience in the organizations that you've worked in? Or does it maybe matter whose perspective you're asking about when you say scheduling barriers and complexities?
Yeah, it has not been the same. I have really dealt with a lot of scheduling barriers in the last 3 organizations I was at. And it really came down to our physicians really, most importantly, want to hold on to their control over their schedules and helping them to recognize we can actually help you with that and make it easier on us to schedule. So looking at block scheduling versus session limits and how to utilize those in a way that it will meet the physician's needs. At the same time, it provides more flexibility for our patients to pick what time works for them. And as an outcome of moving to session limits in this organization, our schedulers are delighted because a lot of the rules that were put into place, it was very difficult for them to find a place, and that goes back to the lag time. It was very difficult for them to find a spot that worked for the provider and the patient. And so that has really improved our third next available and lag time significantly. But every one of these are barriers for me as well. And the one thing I do know, we are in a very competitive location in Cincinnati. There are 4 healthcare systems right here. We're number 3 in the state, number 1 in the area. But our demand, it really does exceed our capacity. But when we started really digging into that, once we fixed some of our scheduling barriers and removed some of our complexity, we could meet more of that demand. So it's really, really digging under the covers to figure out, is it really the demand? Is there some opportunity to improve the capacity without impacting negatively providers and team members? What is the actual problem that you're trying to solve?
And Kim, what about influencing demand as the clinician? You've coached teams on a lot of, frankly, some of these are pretty old school, but strategies for how to influence patient demand from the clinician's perspective. What's your thinking about patient demand and how to influence it?
Well, I think influencing patient demand taps into the higher order skills of providers of all kinds. Explaining that, for example, okay, we now have gotten your diabetes out of danger territory. And now for the next few visits, you're going to be seeing the nurse care manager. And I will see you in 6 months when we will fine tune even further if what you've done with her does not succeed. It also has to do with higher order skills, like with my friend who was the Z-Pak provider in the afternoon, educating patients in a way that harnesses empathy for how awful viral bronchitis feels and how we have evidence that there's no benefit from antibiotics, and a commitment that I will see you soon if the following bad things happen. Plus, did you know that the cough that comes with a cold lasts 3 weeks on average? And these are interactional qualities which providers vary in their ability to perform, and they need protected time during the visit to accomplish it, which then means the higher order skills of how do you run a visit. And this is where we get into what to me is the really exciting part of engineering how a visit works and getting providers to borrow from each other, borrow from the so-called positive deviants. Oh my gosh, how do you do so few low back pain MRIs when I feel like I'm constantly harangued to get them? And then I'm dinged in our statistics about imaging. How do you do that? Providers love working on these problems together. That then builds trust in the group. And then when you say, our finances demand that we find a way to see X more patients per month here, what are our ideas? You have a group that will work together. So I think managing demand is a higher order clinical skill. And in the end, properly facilitated providers love working on that. Whereas if you just tell them 2 more patients per day or hit the bricks, they will say, reduce my FTE and up my burnout scores. My chips are on the table.
Before we move off this slide, Jenny, I know you've got a comment, and then Aaron, I want to ask you a question. So Jenny. Oh, you might be muted, Jenny.
I'm very sorry. I just wanted to comment on Kim's comment about going to the providers and just asking them to do more without us doing anything for them. Because that staff vacancy and turnover was always the pushback that I received. We don't have enough staff. We don't have time. So we had to fix everything else before we could start introducing let's talk about getting to the 65th percentile. Let's see what we can do to help you get there. And then they were more open to those conversations once we fixed a lot of other issues operationally.
And Erin, when we look at the thinking of patient demand exceeds capacity, how should we be thinking about capacity?
Yeah, I think one of the main questions is when you look at your productivity, you look at your space utilization, kind of paired with your access metrics, like in the polling question. I think, if you look at, the question is, are you above productivity? Are you above your space utilization targets? Are you at, or are you below? And I think when you look at those benchmarks, they can tell you directionally, I think, whether or not, okay, you've utilized your capacity, you're at capacity, it makes sense to buy more capacity, versus we have really work to do with the underlying operations, I think, to the point that Jenny and Kim are making. So I think kind of pairing those things up is an important dialogue. So when I see this polling question, I think the first thoughts that are on my mind from the respondents would be, okay, where are you at? Where are you at with your productivity? Where are you at with your space utilization? Are you above average, below average? And what can that tell us about how your operations are working?
Thanks. So Kim, you took us into a little bit, as did Jenny, around improving the operations, but really also changing the approach from doing things in batches to doing the work more as it comes in flow. And that really requires some, you called it re-engineering, the stuff you love to do. Can you talk a little bit on the slide here, or just some of the things that you coach teams to think about doing differently that actually help to improve the efficiency of the visit, and as a result get more capacity in the system? Can you talk about that for a minute?
Yes. First, we have to be virtually or actually shoulder to shoulder co-located so we can communicate with ease. We have to have our stuff where we need it. That's the workplace organization. And we have to get the waste out of those supplies, and also get the waste out of such things as documentation for a provider, for a medical assistant, for an RN, and automate those as much as possible. And we call that kind of improvement external set up to do your job correctly. What I mentioned before in the higher order skills is the inbox management by the team involves higher order skills for the medical assistant and the RN and the provider. And whether you have these in canned responses that are semi-automated to common complaints, or effectively realize which portal message requires a conversation on the phone or a visit, then you're teaming effectively in leveling the work across the team. The same way with setting yourselves up to specify for each patient in each half day, what are the care gaps we need to cover, and what our contingency plans should be run behind. And everything needs to be done in small lots. I see a patient, I document, I do a few portal messages, a few results. I see a patient, I document, I do a few messages, and everyone's work needs to be broken down in small lots or one-piece flow. When this happens, suddenly there's a happy hum in the group, and people are more in flow each half day, and not working during their noon hours, and not staying till 7:30. And worse, most part-time providers are now turning on Epic from 9:30 to 11 most nights and on days off. Can't have that.
This looks like a lot to do. Jenny, you've been working on transitioning providers and teams out of batch and into flow. Can you share a little bit about how long does this take? Looks like it could take a really long time to make this happen.
Yep. We're doing it in 3-day increments with a group. So for example, our pulmonary practice, we had one physician and one APP, and then we brought in their MAs, and we bring in pharmacy, IT, other extra folks to help us walk through this. And then we test it in a live clinical setting. And I will tell you, in pulmonary, It was exciting because the relationship building between the physician and the MA and getting all that work done was remarkable. Then what we do after the 3-day event is we record everything that's working and we begin to spread it across all of pulmonary. A couple of items that have really come out of that is our practice manager in that clinic specifically was opposed to doing this. And now she's our greatest advocate for it. In fact, I kicked off a flow workshop this morning in one of my primary care offices, and she was right there ready to help the practice manager in that office to get this up and running. So it doesn't have to take, it's going to be small sprints, but then as with everything, then you can start to run and spread. And that's what we've been doing here at the Christ Hospital.
Thanks. And there are a couple of comments in the question and answer section I just want to raise. Tom Schumacher is talking about the challenges of scheduling inside of oncology and the serial nature, it looks like, of returning patients and the demand on the schedules that are driven by treatment regimens. Any thoughts from any of the panelists on how to think about oncology? Jenny, I know you worked on that in a former organization.
Yeah, that really does come down to being a team, having a team approach to it with a provider, nurse, even an APP to be able to manage that. I think the most difficult part in some organizations is if it's linked to their infusion, it's harder to delink it. And getting providers to open up to trying to do that and allowing other physicians to oversee the infusion has been one of our challenges here. I do not have the answer to that. But again, if you're working in flow and you're making sure all of the team members are working at the highest level and at their capacity, it does assist in opening up access.
Kim or Aaron, any thoughts? Maybe one other thing I'll just throw in. I think it makes the case for why having the maximum amount of your capacity open and unfettered, in other words, not requiring some sort of qualification, is really critical. But also then being very evidence-based, if you will, on predicting the demand that's going to come your way. Because you could think in some ways that in an oncology practice, you have the benefit of actually a high degree of knowing the volume or the demand that's going to come your way because it's self-generating in some respects. So can you flip it on its head to then use what's predictive about your numbers to then look at, do you have enough what we call elasticity in that capacity, enough flexibility of it to then do what I think Jenny was talking about earlier, the difference between third next available, which really tells you about your system capability, versus lag time, which really tells you about patient choice. And somewhere in the middle there is the perfectly functioning access system.
I have a comment.
Yes, Kim?
And some of these, Kim says, just do this, categories on that slide, involve what some providers would feel is an intrusion into their personal craft, their lone helmsmanship. And there is medical leadership needed to help people realize that every system is perfectly designed to get the results it gets. And if we're not getting results, they give us a reasonable length of day and joy in our work, plus some security economically, then we have to change. And then comes, how do we build the conversation for what doesn't work around here and what we want to make better, and how we will go about it, and how we will each commit to playing a role in the improvement experiments that happen. And this kind of leadership is absolutely necessary, rather than just numbers-based, top-down, you got to do more, which amounts to a buggy whip and will not be therapeutic.
Thanks, Kim. Jamie, our third poll.
Yes, the third poll is what's most important for your patients when it comes to in-person access? Your answer options are timeliness, minimal delay, convenience, location flexible hours, extended hours, digital access or online scheduling, affordability, ability to access a preferred provider, or something else. We'll give it a minute for answers to come in. For those of you that would like a copy of today's slides, you can download them from the folder that says slide deck and handouts. We'll also be sending the slides via email tomorrow, along with a recording of this webcast. Additionally, there are a number of resources in your console that might be of interest to this audience, so definitely be sure to check all of those out.
While we're waiting on the results, panelists, let's talk a little bit about flow busters. What gets in the way of creating flow that you've seen as you've worked to convert practices from really batching their tasks to working in flow? What would you say are the couple of things to really pay attention to?
On the primary care side, seasonal illness, viral illness between the end of October and the end of March always stresses the system. And taking an evidence-based approach and a team-based approach for how to manage acute illness appropriately for patients at different risk levels is one thing that can bust up flow. The other is not centering so much activity in the provider, teaming up in the portal messaging, teaming up in results reporting. And then lastly, I would say, since Epic shows us that providers spend so much time in notes and clinical review, taking a hard look at how people do clinical review. Do they use a summary page? And do they do notes-based research, which will take longer, and working on those as if they're practice patterns, no different than what tests you order and how you manage a disease. And the key benefit of being an Epic user or having an EHR is having something like signal reports to look at honestly every quarter and ask critical questions that the group can engage with about where we spend our time, because therein are the flow busters.
Great. Let's look at the poll. So timeliness. So the thing we've been talking about, timeliness and convenience. Interesting that very few are talking about online scheduling. Jenny, I know you've had some attention to that lately in your own organization. What is the thinking in your organization there?
The thinking would be everybody should be able to schedule online, just like we do in the industry for our dental appointments. The difficulty is there's a lack of trust, I would say, by providers in that system, in that I hear most often anybody who schedules online no-shows, or I'm not putting that out there. I'll get the wrong patient at the wrong time. So a lot of this is probably the hardest operational challenge for me, is how are we going to do online scheduling and that's going to meet the needs of our providers and make sure that we don't have a flow buster where we suddenly have a whole bunch of no-shows. So this is a difficult, I think, operational challenge that we have facing us, is how are we going to flip to that type? And my CEO wants more and more online scheduling. So this is a challenge.
And we've got one more poll. Here you are. If you'd like to get your CPE, drop into this final poll.
Yes, this is our last poll. What is most important to your providers when it comes to providing in-person access to care? Your answer options are control of the schedule, able to leave when they want, able to dictate days of practice, ability to see one's own patients, or something else. Leave this open for about 30 more seconds or so. Once you've completed all CPE requirements, you'll be able to download a PDF of your certificate from the CPE progress window. Also, at the end of the webcast, the survey link will appear. We'd appreciate any feedback you're willing to share, and we'll use that information to develop future webcasts for you.
And Jamie, what is this showing us? Something else. Control of the schedule. Control of the schedule, which goes a little bit back to control of the schedule via what means. Jenny, you talked about this earlier. Blocking the schedule, right knee at 9, left elbow at 10, or using a little higher order functionality like session limits to make the day manageable. I think it also goes to something, though, that you all three have been talking about throughout this broadcast, and I want to turn it to some questions that we have, which is actually making the work so that you can improve the access. Again, access becoming the outcome as opposed to the objective. The access will come if the work is doable, and along with that, so will the quality and improved well-being.
Yes, I would completely agree with that, Marnee.
Let's go to some questions. Oh, go ahead,
Sorry,
Jenny, and then we're going to take a question.
No, I apologize. I would think that once a provider sees that the flow of the work is moving forward in a way that is manageable for them, they are more open to saying, yeah, I can see a couple more patients. And that's the end goal, is to get it to that point. And then they trust the system, they trust the staff, they trust the leaders. Then they're willing to open it up and give us more of that oversight. Thank you.
So we got a question here, how to get started. Jenny, do you want to take this first, and then maybe Kim and Aaron? What would you do, Jenny, to get started?
My first step is always to make sure you have the platform firm, that you have it set. Get the waste out of the way. And then I would take just take a clinic, pick a place, take 2 providers in their MAs, start to look at flow, start learning more about what are all these little concepts, how do you introduce them, and do a 3-day workshop. And then what happens is we are now having physicians calling us, hey, we want to do that flow thing. Hey, can you come? And I never thought my MSK or my ortho docs would even ask for this. And I actually had a spine surgeon call up and ask to do flow. So it works. And once you do it, it becomes pull, and we're not pushing it on them anymore.
Kim?
I think before you get your workshop together, do what Jenny did and do what people don't do enough of, is go and see. Be curious. And my providers who seem to run more on time and seem to bounce along with some happiness in their steps, how do they do it? And my providers who are very stressed and always want 40 and 60-minute visits, well, how do they do it? There are really only 2 clinical reasons for those long visits. And those are frailty, that's people with neurologic disorders and dementia and end-stage cancer, and anxious patients. And managing anxious patients is an acquired skill, and that goes to the clinical interview and the higher order skills we were talking about, which providers can learn from each other and refresh, even in their late career. And that might blend into what your workshop is about. We might have one provider who's very stressed and runs behind, and another who's bouncing along, and put them in that workshop together. After you go and see what the patterns are. The providers will be grateful that you believed them, what they've been telling you for weeks and months.
We're rapidly running out of time, so I'm going to blast through takeaways. These are from your panelists, and I think we've hit on these points. Improve the way you do the care to improve the well-being of your providers. Those are synergistic activities. Move to flow rather than batch. You saw the evidence for improving your quality and well-being. And as Aaron made the case, access is foundational to everything strategic and financial you're trying to accomplish. We've hit on some questions already. There are additional resources here that are available on your screen, and we'd love to hear your questions. So feel free to reach out to any of us, and I think this information will be available to you in some follow-up information you'll get from the firm. And thank you for your time today. Thank you, panelists, Jennifer Berry, Aaron Adams, Dr. Kim Pittenger. Appreciate your sharing your knowledge and expertise today with our guests. Thanks, everybody. Have a great day.
Just a reminder to the audience, if we didn't have time to answer your question, we'll follow up with you after the webcast. If you met all CPE requirements, your certificate is available to download now in a CPE progress window. A copy will be emailed also within 3 weeks should you have any difficulty downloading. Finally, here is a link to an online survey for today's presentation. Thank you for joining our webcast, and we hope you'll join us again next time.